So thank you very much, Sonia, for that lovely introduction. And I want to thank you and, Navena, and I want to thank you and Sonia and Patricia for inviting me here, and for everyone who's stuck around. My last couple, I just arrived from Bangkok, and so first of all, I'm very impressed by the ability of everyone here to conduct an entire meeting in a language that is not an official language of your country. That's very impressive, and I'm suffering from quite a significant amount of jet lag, so I'm hoping my cognitive dissonance isn't going to mean that I misspeak in my own home language. I'm also cognizant that my work in childhood research is more focused on intervention research, and in the recent years I've been also more involved in implementation and dissemination science as we look at how to transfer and take to scale evidence-based interventions, mostly in violence prevention, but also in preventing child behavior problems and improving child outcomes. My last few talks were actually a 4-minute talk and a 5-minute talk. So I think I've been exercising as a sprinter, and now I feel like I'm going to have to be more of a long-distance runner to get us over that finish line to the cocktail party that will follow. So I hope you stick around for the entire talk. So just a brief on the structure of this talk. I will first give you an overview of early childhood development and parenting interventions and science in low and middle income countries. And then I will discuss some of the challenges that we face in scaling up programs, some of the concerns and criteria that we should consider when we want to take programs to scale. And then I'll use 3 case studies of work that I've been doing with the Parenting for Lifelong Health initiative as examples of how we can harness empirical research in order to really learn how to study the scale up and dissemination of interventions. So I was blessed with a very wonderful childhood, a very supportive family, had lots of playfulness in my upbringing and lots of family time. And I'm the one with the mug, by the way. So this one with the 1970s haircut. I think this is 1980s. My brother's alive then. I had a lot of opportunities to play. And sometimes I also misbehaved, and here's a picture of myself and my sister in a timeout on the stairs. And the timeout on the stairs was the least effective place to put a kid on timeout because you could sneak upstairs into your room if you were quiet as you went up the stairs. But I'm also cognizant that I was blessed with a very happy childhood, but a lot of children, especially in the global south, face very different circumstances, and we know from even advances over the last 5 years in implementing early childhood interventions, still 250 million children under the age of 5 are at risk of not reaching their developmental potential, and 1 billion children each year, ages 0 to 18, experience some form of violence. And that's a really shocking number. And if we were talking about like communicable diseases, we'd be all up in arms trying to prevent violence against children or to improve child development outcomes. But it doesn't get the same headlines as other diseases and concerns. We also know that early child development and violence are linked by similar risk factors, including poverty, poor health, nutrition, stunting, psychosocial deprivation, intimate partner violence. And we also see long-term effects of health, violence and delayed development on health, learning behaviors, and even poor economic outcomes later in life. The World Health Organization and UNICEF have this nurturing early child development care framework that I'm sure some of you are familiar with that looks at supporting good health, adequate nutrition, opportunities for early learning, and security and safety, and responsive caregiving. And within all of that is the role of the caregiver. And the main focus of the nurturing ECD care framework is really to strengthen caregivers' capacities, knowledge, attitudes, and behaviors, and also to create a sense of support around that caregiver so that they can have supportive parenting and to increase their access to quality services. And we know from over 50, 60 years of research on parenting that it does have a major impact on early childhood development and later child and adult outcomes. And we know that positive, consistent nurturing parenting can predict better child and parental mental health, school readiness, partner relationships later in life. And we also know that harsh and inconsistent and dysfunctional parenting predicts a whole course of negative outcomes, including child development, poor behavior, higher rates of behavior problems, juvenile delinquency, crime, drug use, family violence, school failure, poor health, and even intergenerational transfer of violence between two children, and greater likelihood of perpetration of intimate partner violence and also victimization. We also know that these kind of poor outcomes of poor parenting and abuse are very costly, and there's been research on the cost of violence against children or poor parenting that looks at over $500 billion in the US and up to 2.3% of GDP in East Asian countries. And we also know that parents who are particularly facing a lot of adversities require extra support in raising children for the next generation. But the good news is that there's also a lot of evidence and knowledge on how to improve parent skills and how to engage them in improving the way they interact with their children. So it's really a logical choice that we would look at focusing on improving parenting skills and parent behavior as a way of early intervention. And when I use the word parent, I mean any caregiver who's responsible for the well-being of a child. So what's an effective parenting intervention? So most evidence-based parenting programs are across the world based on a lot of the component analyses and meta-analyses find that parenting interventions are based on the similar content and scientific principles. A lot of them are either grounded in social learning theories or attachment theory. They work on focusing on developmentally appropriate expectations that parents should have for their children. They focus on encouraging nurturing relationships and positive parenting skills, and then also looking at learning nonviolent alternatives to harsh discipline and punishment, and also looking at reducing parental stress and depression. When we look at the developmentally appropriate content for early childhood, we can see that most interventions include an aspect of increasing attachment, sensitivity, nurturing care, relationship building, and it's often integrated with other early childhood development interventions like nutrition, health, stimulation, and safety. When we look at the younger child age at the onset of child behavior difficulties, you would include all of these components as well as focusing on positive discipline and behavior management, limit setting, rewards, and alternatives to harsh punishment. And then when we get into adolescence, it becomes a little bit more complicated when we're engaging with adolescents around negotiation with teams, communication, monitoring, and keeping them safe. We also know that parenting programs, for the most part, focus on parents learning skills. And now we know that changing behavior is very difficult. And if you've ever gone to a workshop or a training of some sort of behavior change and feeling great afterwards and being like, I'm going to do this and that, and then, about a week later, you've kind of regressed to the way that you have been in the past. That happens to me after every meditation retreat I go to. I know that behavior change is very hard, and it's especially difficult for those who are experiencing a lot of stress. And so it's really important that parenting programs are sequential and that they give parents the opportunities to practice skills both in sessions and at home, and then get the support from a trained facilitator in order to be able to problem solve over difficulties experienced and to reinforce those skills. We also know that parenting programs can be from a variety of different delivery systems. They can be home or group-based, though often now we've seen more and more parenting interventions delivered to groups of parents within communities. They can be delivered on the levels of schools and in daycare centers, clinics, mosques, community centers, even at the workplace. And on average, the most effective parenting interventions are between 8 and 12 sessions, although we have seen some evidence of effectiveness for shorter, more brief interventions, especially those who do not have, that are not focused on treatment, but more on prevention. And then also that even though the group setting is important, that it's still important that there are smaller groups that can allow for active participation and for the facilitators to give parents an individualized approach and attention within that group setting. So what is an evidence-based parenting program? Well, I'm sure you've heard people have heard about Triple P. I know there was a study that happened, I think, in Zurich or Geneva that didn't go so well, but it still has a lot of robust evidence across the world. We also know that there's Incredible Years, which is another very highly regarded evidence-based parenting intervention. There's Parent Management Training Oregon. There's Parent-Child Interaction Therapy. There's a Nurse-Family Partnership. And there's a Strengthening Family Program. And in many ways, you can think of these as kind of like detergents. And so there are many different brands, but they all have the same kind of core components and based on the same principles on really derived from over 60 years of research like we have just been talking about, of looking at focusing on modeling learned behavior, supporting positive parenting before discipline, giving positive reinforcement to promote good behavior, such as praise and simple rewards, and using positive, specific, and realistic instructions to help improve compliance, and then dealing with negative behaviors like using ignore for tantrums and other negative attentions or demanding behaviors, or using consequences or timeout for aggression, and also looking at realistic expectations that parents can have for their children. So how do they work? Well, we can look at a program and we can look at what's inside a program manual, and you can see that there are these core components that are behavior management, stimulation, relationship building, stress reduction, and they will have proximal outcomes like reduced harsh parenting, and improved cognitive development, increased parental involvement, and reduced reactivity or stress that will eventually lead to reduced behavior problems, maltreatment, or improved child development. But it's not really enough just to think about what's in an intervention. You also have to think about how the intervention is delivered. How are you going to increase engagement, increase dosage and completion of programs, and also to look at making sure that the program is delivered with a sufficient level of quality and fidelity. But that's still not enough, because we also know that there are a lot of drop-off effects in interventions. And so there's also the issue of program sustainment, and how are you going to sustain the skills and behavior change both for the parent and for the child. With looking at different systematic reviews and meta-analyses, we have evidence from high-income countries that parenting interventions can reduce child behavior problems, reduce child maltreatment, reduce depression. And we also have emerging evidence in low and middle-income countries, including a review that we are just submitting for publication that identified 93 studies across 28 countries, which was an increase from only 12 that were identified in 2013. Now, some of this is because we had more sophisticated searching strategies, including looking at Chinese databases and databases in Farsi. So we were able to identify quite a number of trials in China and Iran. But also it shows that there's a lot more research being done in the Global South on the effectiveness of parenting interventions. Unfortunately, we have not found very many studies that look at the cost effectiveness of parenting programs in low and middle income countries. But we do know that transported and homegrown programs are equally effective, and that depressed parents or children with severe behavior problems tend to actually do better than those who are not. And we also know that poor families, single mothers, migrant and ethnic minorities in high-income countries do as well as those who are not. And that one thing that's very encouraging is that there's equal effects for both young and old children across the ages of 2 to 10 years old, so that it's never too late to really engage families in positive parent-child relationship building. So all of this has led to parenting in early childhood to be a key factor, a key part of the Sustainable Development Goals, and especially in Target 4.2 to make sure that all children have equal access to early childhood development and primary education so that they're ready for later education. But early childhood interventions also affect the Sustainable Goals for no poverty, hunger, and health and well-being, and they also affect those for gender inequality, reduced inequalities, decent work and economic growth, and peace and justice around violence against children and violence against adolescents and women. So it's really across many different goals that we can really think about how the importance of scaling up interventions for early childhood, especially around parent-child interaction. So what do we mean when I say the word scale up? And this can mean many different things. And sometimes people say we're scaling up the intervention, but it's really going from like 10 to like 400 families. And so we're using this definition called by Milat, which says that scale up's really the ability of an intervention that is shown to be efficacious on a small scale or under controlled conditions to be expanded under real world conditions in order to reach a greater proportion of eligible populations while retaining its effectiveness. And this is really the key issue, is like it's not enough to be able to deliver the intervention to a wide number, a high number of beneficiaries, but it's also essential that when we scale up interventions, we are able to maintain that program effectiveness. But there are a lot of barriers to scale up that we have encountered in many different fields, not just in the fields of parenting and early childhood interventions. First of all, there's limited financial, organizational, and human resources and capacity in many low-resource settings. Also, a lot of times, a version of the program that's tested in a randomized control trial is not actually the scalable version. Either it's too costly or the program is too complex, and so when you start to try and implement that on a wider level, then it cannot be done. There's also a lot of lack of readiness on the level of implementation. There's also a need for buy-in and engagement of stakeholders, and then that results in poor implementation due to lack of understanding of how to deliver the program and how to sustain it beyond the first infusion of technical capacity support. And also we see that there's a lot of limited research capacity in low and middle income countries and the ability to use innovative designs to monitor and evaluate scale up. So we don't know exactly when we take a program to scale, is it still having that effectiveness that it was in that controlled trial? And so often we end up making these poor choices. We either simplify a program by making ad hoc changes that aren't based on evidence, and so we cut content or take out materials or make compromises on staffing or remove supervision or support. Or we decide sometimes to use another intervention because it's a lot cheaper, but it might not be tested. So there may be a political reason why we decide to choose that intervention. Or often, like we see, a lot of interventions aren't used. They've been rigorously tested in randomized control trials, but then they sit on the shelf in academia because nobody's taking them up or there isn't a engagement with policymakers. And this often leads to bad consequences. There's a bottleneck of many evidence-based programs that are not being delivered to those who need it most, or programs get changed so dramatically that they no longer reflect the evidence based upon which they had been developed, or they are rolled out but they're not tested because it's more user-friendly or affordable. And so this can be actually a colossal waste of limited resources in poor resource settings. And not only does this have an issue for Global South, but also in your context, for instance, in Switzerland, we do not want to waste valuable taxpayer dollars on interventions that don't prove to work. So we have established these 4 core criteria that one should consider when taking any program, including parenting programs, to scale. And that's to make sure that there's evidence of effectiveness, that the program is economical and efficient, that it's transferable and contextually relevant, and that it's sustainable and scalable. So the first criteria is on the evidence of effectiveness, and this is really to establish, does the program achieve the outcomes that we are intending it to achieve, and can we be sure that those changes are a result of the program? And so when we look at criteria around this, we're looking at having numerous rigorous evaluation methods or numerous randomized control trials to establish that the program is not just in one trial being effective, and that it needs to show improvement on that primary outcome that we specified, but also it's important to look and examine secondary outcomes or unintended outcomes. And one of the trials we just recently completed at post-test, we found that it reduced intimate partner violence, even though that wasn't an intention of the intervention or the trial. Also, it's very important that the programs demonstrate short-term, but equally important, long-term effects, and that we examine for whom the program works and whom it doesn't to see if there are vulnerable populations that might need more engaged and more support. The second criteria is around economical, making sure an intervention is economical and efficient. And that's really to assess whether the program is cost effective, but also does the program make the best use of the limited human and financial resources. And we really want to make sure that programs avoid wasting time, money, or staff. We want to make sure that they are effective without exceeding budgetary constraints and that they offer a good value for the money. And this is really key, especially when you're trying to advocate for these evidence-based interventions and you're working with, instead of like a Department of Social Development or a Department of Health, you're working with a Treasury Department in a different institution. And also we want to make sure that there's potential economies of scale where the program, when it is scaled up, will reduce costs. The third criteria is making sure that programs are transferable and contextually relevant. Can they be transferred to other settings for other populations? So even within Switzerland, you'd want to know whether a program could be equally effective for the different populations that are within your diverse country, but then you could think about how is it transferable across to another country or another setting, and also to know whether the program is acceptable and feasible in the local context. And here we're looking at how to maintain core program elements while recognizing diversity across contexts, to also acknowledge that there are local cultural beliefs, values, and needs that could be harnessed to improve intervention effectiveness, and to develop some inherent flexibility of an intervention so that it can fit in different multiple delivery systems depending on what would work best in that specific context, whether that's within early childhood development centers or health clinics or a home-based or a school-based intervention. And the last criteria is really about scalability and sustainment. And so we're looking at whether a program can be delivered at that scale and does it maintain effectiveness. And here we want to see how can we integrate a program into the existing services? Can we replicate it over and over again? What kind of training and supervision is necessary for that? Do we have the sufficient resources and commitment from agencies to sustain the intervention? And is there that engagement and buy-in from different stakeholders? So taking all of these 4 criteria in consideration, I was part of the beginning of an initiative called Parenting for Lifelong Health, which was started with partners from UNICEF and the World Health Organization and different universities and NGO stakeholders. And it was reflecting on the fact that there were very few scalable parenting interventions in the Global South that were also freely available and open sourced. And so the main objective of Parenting for Lifelong Health was to develop and test a suite of parenting programs that was across the development spectrum that could demonstrate rigorous evidence of effectiveness, mainly focused on reducing child maltreatment, but also improving child outcomes, making sure that the programs were affordable and scalable, and that they were open source and freely available. And so the program material for Parenting for Lifelong Health is available for free on the World Health Organization's website. And so there are these 4 different suites, parts of the Parenting for Lifelong Health suite. They're not specific programs per se because there are variations between all of them. But for the most part, I'm going to focus on the work that I've been doing with Parenting for Lifelong Health for young children ages 2 to 9, although some of the studies were for ages 2 to 6. And so this is the program model that we use for explaining the intervention to families, but also for kind of having a model of building a house of support for you and your child that is really based on the HANF 2-stage method, where it's importance of establishing positive parent-child interaction before using nonviolent discipline and behavior management strategies. And the program is delivered over 12 sessions, either weekly or every other week, to groups of up to 15 parents by 2 facilitators. It has individual consultations in order to establish parent goals before those group sessions. And then it has a lot of different support systems that are including like text message reminders and phone consultations. It uses illustrated stories and vignettes to model core parenting skills and make sure that parenting skills parents can practice those skills during the sessions and at home, just like we were just talking about. So it's really modeled on what we know, what works within evidence-based parenting interventions. And there's been a number of trials that have been looked at across the different Parenting for Lifelong Health programs, including 6 in South Africa, and then 1 in the Philippines, and 1 in El Salvador and Lesotho, And we've seen a wide variety of positive effects, including for the babies and toddlers, improved child development, maternal sensitivity, responsivity, HIV testing for children. And then for the children, we've seen improved positive parenting and efficacy, reduced maltreatment, dysfunctional parenting and child behavioral problems have been reduced. And with the teens, we've seen improvement in positive involvement, family budgeting, reduced maltreatment, and reduced parental stress and depression, and encouragingly, adult and teen substance use reduction. So the programs were started and developed and incubated in South Africa, which is actually the country where I was born, although I did grow up in the United States. And after the initial testing, the programs now have been very rapidly, over the last 3 years, disseminated into over 22 countries for more than 400 families targeted by the year 2022. And this has given us a great opportunity. It's been a bit mad, to be honest, and very fast. And actually, that's why Patricia was asking me where do I live, and I actually don't have a home because I am traveling quite a lot to support these interventions and support the dissemination of the program. But it is also a very exciting opportunity to study the scale up of interventions on a wide level. And so for the remainder of my talk, I'm going to give you 3 different examples of how we've worked to evaluate the Parenting for Lifelong Health program for young children. So the first case study is looking at how we integrated this within an existing service in the Philippines. And then the second case study is how we are using the multi-phase optimization strategy framework to optimize parenting for lifelong health in Southeastern Europe. And then the third is how we've been trying to really look at the scale up of parenting evaluation research across sub-Saharan Africa. So the first is in the Philippines, and this is really focusing on how to integrate the program within a conditional cash transfer system so that it is for parents or families who have fit a certain income level who have a conditionality that they have to participate in family development services once a month or every other week as a condition for them to receive their cash grant. And the government, the Department of Social Welfare and Development, had already an existing parenting intervention, but it wasn't based on evidence. It was very lecture-based, and they wanted to replace it with something that was more effective. And so they found out that the Parenting for Lifelong Health intervention was freely available, and then they requested whether they could integrate it within their system. And we saw this as an opportunity also to test its effectiveness. And so in the first phase, we were focusing on how to culturally adapt the program. And so this model is really taking a very systematic approach to transferring an intervention from one context in South Africa to the Philippines. And part of that was to do a very rigorous cultural adaptation process based on the kind of model proposed by Barrera and Castro that first included a needs assessment with stakeholders, and then a program adaptation period that we were looking at doing design workshops and presenting materials to potential users, developing the content, and then also looking at capacity building and training and selecting facilitators. And so the model that I had presented earlier of building a home of support was transformed into a tahanan of support, which is the Philippine version of a home. We also have, this is a illustrated story from the South African version that is looking at the importance of positive attention, or the attention principle, where children will do anything, even negative behaviors, to get negative attention. And we use the cell phone as a good model of how also parents modeling what's more important for them, their children or their phones. And this was then transferred into a Filipino father who is engaged. So you can see how the cultural transformation was done in a kind of on a surface level. And it was then tested in a pilot evaluation where we did just a pre-post looking with mothers of children ages 2 to 6. And this was funded by the UBS Optimus Foundation. So very nice to have the support of Switzerland in the research that we were doing in the Philippines. And our findings, besides the quantitative findings, which showed positive effects on reduced maltreatment and child behavior, we also did in-depth qualitative research, and we found that parents reported that the program helped them reach their goals, especially within compliance, and that there were fewer negative child behaviors. But we also found that the parent behaviors had changed, that the parents were more calm in interacting with their children. And one important element that we included in the intervention was a mindfulness-based family-based stress reduction activity called Taking a Pause. And this was something that they actively reported that was an active ingredient in making them less reactive to their children's negative behavior. And another core ingredient was the spending more one-on-one time with their children and the positive interaction that happened in there. Then we tested the program in a randomized control trial with 120 parents, and these were families. The feasibility pilot were families that we recruited from a local neighborhood, low-income neighborhood, but they were not part of the conditional cash transfer system, whereas these were actually integrated within the system. And we then did a 1 month and a 1 year follow-up evaluation. And here you can see the results on our primary outcome for child maltreatment reduction. We can see that at 1 month there was quite a large effect of reduced maltreatment when you compare both the intervention group, which was called Masayang Pamilya, or a MAPA program, with the controls, and that this was sustained at 1 year later, which was very encouraging and very positive to find out. Also kind of nerve-wracking to see what the results would be like 1 year later. And we saw a lot of different positive effects at 1 month post-test along with that primary outcomes, including dysfunctional parenting, less problem behavior intensity based on the IBERG child behavior inventory. Also, we saw less daily child behavior problems, more positive parenting on a daily basis, and more parent self-efficacy and less intimate partner violence, as I alluded to earlier. But we didn't see differences on a number of other outcomes, including parent mental health, attitudes towards punishment, child behavior problem frequencies, and child development outcomes, or marital satisfaction, which is why I asked that question earlier, because we just had really high positive ratings at baseline, so there was nowhere, there was a ceiling effect, there was nowhere they could go. And we used the Kansas Marital Satisfaction Survey, which I think I'd rather have something else that maybe is a bit more robust. But we also saw no negative effects. But then at 1 year follow-up, we only found positive effects for our primary outcome of less overall maltreatment, emotional abuse, and neglect, and no other outcomes were sustained at 1 year follow-up. So this brings that question of sustainment, and we are hypothesizing in our next round of evaluation that the fade-out effects might be because these are parents that have a lot of adversity and they might require some booster sessions. And fortunately, there's a system for that already in place within the conditional cash transfer. So they are receiving other forms of support. And so perhaps this is something that we can explore in our next phase 3, which is to do a 3 province-wide multi-randomized control trial with 540 families. In this sense, this will be government-funded instead of NGO or UBS Optimus-funded intervention, and that we will be working with actual people who are on the front lines of service delivery. And it's really important here to develop those systems and capacity. And so some of the good practices that we've learned from this 3-year process is that it's really important to have that multi-sectoral collaboration between both Filipino and international researchers, but also child and family practitioners and local and national government officials. Also, the benefits of applying a very systematic and rigorous method to culturally adapting, testing, feasibility, and scaling up. And also the encouraging ability to test a program within an existing service delivery system. So the second case study that I'd like to talk about is this optimization study of parenting for lifelong health. And this is funded by the Global Alliance for Chronic Diseases and Horizon 2020. And it is really looking at how we can optimize the program in 3 southeastern European countries, in Moldova, in Romania, and in North Macedonia. And the main focus is to reduce child behavior problems and maltreatment. And we're using this multi-phase optimization strategy framework, which is really an approach to adopt an engineering approach to resource management and to optimizing a program, really trying to balance this issue of effectiveness with efficiency, economy, and scalability. And it was developed by Linda Collins from the Methodology Center at Penn State University. And it's really about how we can identify the most effective, cost-effective, and scalable components, and really to identify within an intervention which components are effective and which are not, that we can then no longer use, or component levels, which component level is more effective. For instance, whether something at a high or a low level is more, or is there no effect, and then you would want to take the lower level component. We also want to look at how components affect each other, and does a component actually offset the cost of inclusion. So this is being conducted over 3 different phases: the preparation phase, an optimization phase, and an evaluation phase. And it's quite a complex study because we're trying to have kind of some sort of comparability, but also unifying aspects across these 3 different countries and 3 very different contexts of intervention implementation. And then the first phase, the main purpose was really to establish the theoretical foundation and practical groundwork for the optimization. And this was in a feasibility pilot study where we looked at adapting the program very surface level and then delivering it for 120 families across the 3 different countries. And here you can see the results for both the externalizing symptoms for both the older children and the younger children, with quite large effects. But remember, this is just pre-post with no comparison groups. So it's encouraging, but it's not definitive. But we also found that the attendance and engagement was quite vulnerable to many different external factors, especially summertime. I never realized that doing an intervention in the summer would be really important. We also found that supportive supervision was helpful in maintaining quality delivery, but was quite expensive and resource intensive, and that the sustainment really required an ongoing engagement from the implementing agencies. So then phase 2, our purpose was really to identify those effective and most cost-effective components, and we used a cluster factorial experiment testing these 3 components across 3 sites. And we looked not just at the effectiveness of these components, but also their cost effectiveness. And just to take a little methodological kind of side ground, what is a factorial experiment? Maybe some of you might not be as familiar with this method, but it's really ability to test 2 or more factors at 2 or more levels per factor. And it's coming from the field of engineering research, and it's used to select those different interventions. And while a lot of people are like, why would you bother to use a factorial when we really should be going to testing the effectiveness of the intervention? And it really depends on what your research question is. If you want to see whether an intervention is better than some sort of comparison, then an RCT would be the gold standard and test for using that method. But if you were going to look at whether a component within an intervention is more effective, you can actually test multiple components within the same experiment, and you can look at interactions between those components, which requires less participants and less money than if you were going to do a long series of randomized control trials. So it really can also look at the testing of interactions between components. Does the presence of one component offset or increase the effect of another component, which RCTs cannot do? So this is one of the reasons why we chose this design. And we looked at these 3 different components: program length, testing whether 10 or 5 sessions was more effective, or engagement boosters, so a basic package or enhanced package that included text messages, phone call consultations, and different incentives within intervention, like awards for high participation. And then we also tested fidelity boosters, and this was looking at really whether or not you need this really intensive structured supervision using video feedback. So here's our conceptual model, and you can see that the components are related to proximal outcomes that are implementation outcomes on participation rate or program fidelity, but those would then have an impact on both dysfunctional parenting and positive parenting, which would then reduce, hopefully have an impact on child behavior problems. And so we might not find an effect on the components on the primary outcome of child behavior problems, but we would find maybe an effect on more proximal outcomes that are closer to the different intervention levels. And we're also looking at different moderators of these effects across the sample. So when you do a factorial experiment, you have, in 3 components, you'll have 8 conditions, but we're not testing the effect of each condition. Instead, we're comparing all the conditions that received the shorter version of the program with those who received the longer version of the program. And at the same time, in the same experiment, we also can test those who received the basic engagement package versus those who have the enhanced engagement package. And then we can also compare the groups that have received the structured supervision versus the on-demand supervision, and we can look at all the costs of each condition, each component, to also evaluate the cost effectiveness. So it's a very kind of cost-efficient way of doing a study. And in fact, you can say there are kind of like 3 different randomized control trials. Just the comparison groups are whether your research question is on-demand versus structured supervision, or enhanced engagement versus basic engagement, or a short version of a program versus a long version of the program. And what we do with that information then is have this decision-making process where we will first look at whether the component is effective. And then if it is effective, we will ask the question, is it cost effective? Now, if it is, it will then be retained in the final intervention packet. But if it's not, we would revert to the lower level, for instance, like a shorter version of the program versus the longer version of the program. Also, if it's not effective, we'd look at whether it interacts with another component. And then if it does interact and increase in the interaction as a positive interaction, we would also look at its cost effectiveness and then include it in the final intervention package. The last, and then we'll be testing this program in the optimized program in a randomized control trial. So the last case study that I wanted to present is how we are trying to tackle this wide-scale implementation, dissemination of the Parenting for Lifelong Health programs for currently over 250,000 families across 22 countries. Now, some of them are being implemented in part of these large-scale delivery projects funded by USAID, PEPFAR, and those are mostly in sub-Saharan Africa, and the program is combined with other program components such as economic strengthening, child protection, gender empowerment, HIV prevention, and they're being delivered or run by large institutions like Catholic Relief Services or PACT Tanzania or PACT Global. But then we also have this opportunity to look at the systematic scale-up in partnership with academia, such as the Philippines program or the project that we're doing in Southeastern Europe, and that gives us an opportunity to pool the data from all these different randomized control trials and feasibility pilots. And the different questions that we're asking in this study is, first, what is the process and extent of the dissemination? Because that's also a black box. Even though we know this target number, we don't actually know how they are delivering the program in some of these contexts. And sometimes we've gone back and they say, oh, we're doing the program. And you ask them, oh, what kind of program? How are you doing it? And a 14-session program is now like a 7-session program that's done once a month and has drifted far away from the original design. And then we're also looking at what is the level of implementation of PLH and what are those factors that are associated with improved or higher levels of implementation outcomes. And then taking all that data together, we would like to look at the impact of Parenting for Lifelong Health, looking at both the pre-post data, but then comparing it to RCT data or historical controls, and seeing if there are differences across different cultures and contexts. And lastly, we're looking at what are some of the barriers and facilitators to sustain the Parenting for Lifelong Health programs after initial funding from USAID is over. And so the data collection is quite interesting and very problematic. First of all, we're collecting mostly secondary data that's from routine monitoring and evaluation collected by under-sourced implementing partners that sometimes do not have the ability to collect this data, but it's looking at like getting reliable attendance data, fidelity checklists, and pre-post questionnaires with very shortened scales. So we might take a full scale like the SDQ and then only choose 2 or 3 items that are most predictive of effects and use those instead of the full scale because they just don't have the capacity to ask the questions or to conduct more rigorous assessments. But then we also will be using primary data, which is mostly qualitative, with interviews with organizational leaders, coordinators, facilitators, and then also looking at cost data and financial reports. But this is this is now we're in our first year, ending our first year of the project, which is a 4-year project, and we've already found a lot of challenges, especially in the limited capacity for partners to collect that data. And that will lead to a reduced quality of that data, and that will compromise our ability to analyze it, especially due to missingness or different kinds of bias. So we're trying to model different ways to account for that. It's also been very difficult to get ethical approval from 22 different local IRBs, along with the lead institutions, and then to also get just the logistics of doing data transfer and making sure that their agreements are in alignment with each partner and the partner's donors, and sometimes multiple partners, is very complex. So just in summary, scale up is hard, but I do believe that it's possible, and I believe that this is a really exciting new area of research, especially in the behavioral interventions. And some key issues to think about is to look at these innovative methods that we can use to optimize the programs for scalability, but also the importance, while we are doing important innovative research, that we are also actively trying to strengthen the partnerships between researchers, policymakers, practitioners, and philanthropic institutions, so that everybody's working together for the same causes. And there's also really important, but also an opportunity here to build the capacity for researchers and implementers in low and middle income countries. And lastly, it's really important that we consider issues of scale up at the beginning of intervention development and testing, and not after we have an effective intervention, because then again, we might have to go back to the drawing table and redevelop the program because what we developed was no longer scalable. So thank you very much for sticking around, and I look forward to answering any questions and also celebrating the first annual meeting over cocktails. Thank you.
Hi, Jamie. That was a fascinating talk. I was just curious about your thoughts on more minuscule, if to consider your programs more holistic interventions, such as you're probably aware of the meditation interventions that are run at Oxford in adolescents, right? And others, such as the direct cash handouts to people that are run by, for example, by Kimberly Noble. I was wondering, what are your thoughts about these more effectively more limited and more prescribed interventions?
I think that we're bringing in also, thanks for the question, bringing on issues of the, like, from a health economical perspective. It's a very good question, and it'd be interesting to test. Well, first, what we've done within the kind of in the conditional cash transfer study in the Philippines is to test like a more robust intervention versus a lighter touch intervention in the context of the conditional cash transfer. But the issue of testing these more large scale but easily to deliver interventions is I think an important component. And if you look at the World Health Organization, they have launched this INSPIRE framework to part of a global partnership to end violence. And in that, they have these different strategies. One of them is economic strengthening. But I don't think that discounts the importance for parents to actually learn effective skills on how to manage difficult child behavior, which is something that high-income families have just as much problems as low-income families, that even though those might be more vulnerable. So,
just a follow-up question: do you have any idea about those stakeholders trying to influence, I don't know, the founders or national funding agencies to be facilitating people try to take a more holistic approach to interventions, or is that not?
No, I think that is actively being promoted by institutions like the World Health Organization and like the Global Partnership to End Violence. And I was last year this time in Cambodia, where they were launching this INSPIRE framework, and so there were presentations on all the different components of that framework, including like strengthening schools, including parenting interventions, norms and values, looking at changing laws and enforcing laws, making safe spaces. So that was a very holistic approach, and that was really being led by by UNICEF and the World Health Organization. So, thanks.
Really wonderful talk. Very, very interesting. I wanted to ask about the scale up. I know it's quite difficult to do, but what are some of the, I guess, oddest things you have had to encounter issues with the ability to scale up? Because I know that a lot of the countries that you were mentioning are quite different from one another.
So I was saying last night that, thank you for that question, one of the things that I took for granted was how easy it is to I found that it was relatively easier to conduct studies and to deliver interventions in some of these low resource settings. So we get higher retention rates actually in poorer countries. But when we start into delivering program in Romania, it's so hard to get parents to come to the intervention. And we can't conduct home visits and develop that trust with them beforehand. And I found that was quite odd. I thought it would be the other way around. So that was one interesting issue. I think another thing that we've discovered in Thailand in the work that we're doing there is the advantages of having both a top-down approach to scale up as well as a bottom-up. So at one time, on one level, we're engaging the Ministry of Public Health's kind of Secretary General, who is making a policy that all of the health promotion hospitals need to deliver interventions, and what he says everyone needs to do. But we wouldn't get quality intervention if we weren't also working at the health promotion hospital level. And what's been encouraging is that even though this is in health, they are seeing the benefits of engaging parents in early childhood rearing and development. So, thanks.
Thank you for your very inspiring talk. I was just wondering, you mentioned that sometimes you're actually linking the delivery of the intervention program to the, what's it called, cash delivery program. Do you think there might be potential difficulties with that in terms of, I guess I'm thinking about fidelity, I'm thinking about social desirability, coming back to the issue, and also what is the real motivation of parents participating in the program? I'm just wondering, has that been an issue for you? And if yes, how are you tackling it? Or
it was actually one of our main questions when we started doing this work. We first had assumed that we'd get very high participation rates within a program that was delivered, that was one of your conditionalities was if you attend, you get money. But actually the attendance rates were about similar to what we found in South Africa, where the conditionality did not exist. Whereas in Thailand, where we've had a lot better engagement from the public health officers, we've had unprecedented numbers of attendance rates of over 90%. One issue is that the conditionality, there's corruption within that. So even if you do not attend, whether you're attending the family development service or the parenting program, sometimes you can get people to sign for you and then you get that cash transfer. So the incentive might not be a true incentive. But another thing about within the social desirability, I think because both groups are getting the conditional cash transfer, I think that might wash out in a larger sample size, but we have encountered some difficulties when looking at how to deliver a program that fits within that system. And so the next round of our testing, when we actually use parent leaders who are volunteers in their community, who are the only people that actually the government of the Philippines could afford to have deliver the program, that's where we might have issues with fidelity and quality of delivery. But it is, there was an ethical issue also considered, and I think that we would feel a little bit on less stable foundation if this wasn't a program that was replacing an already existing program. So in that sense, the withholding parent education because you don't, or withholding money because you don't want to come to a parenting intervention would be an ethical issue. But within the context of our trial, you would just get moved, you would just have to do the regular services if you decided to drop out of the intervention. The government's very keen on testing the program for outside of the conditional cash transfer, and it'd be interesting to see if we could do a factorial experiment to look at whether that has an effect on attendance rates. Thanks.
Jamie, this is very important and very brave work, and so I have a selfish question, and that is when you I don't know what the technical word would be, but when you already have a delivery system in place, like you have in or you are developing in so many of these different places. Is it possible to consider sharing that in a sort of piggyback way? I'm thinking, you're doing a very particularly focused intervention. I know other people in the World Health Organization are doing another type of intervention, but they're targeting parents as well. So is there a discussion of sort of scaling? It's not really scaling up. I don't know what the technical term would be. Like piggybacking on the elegant work that you're doing in the field to expand the focus of an intervention.
So that's also a really important issue and question that sometimes actually the parenting intervention is the piggyback. So like for instance in the PEPFAR they have this DREAMS project where they're providing an array of services including HIV testing, voluntary counseling and testing, women's empowerment, community activation, economic empowerment, and then they have to also do parenting interventions as one thing. So it's part of this array of services. And another situation that would be in the Philippines where the focus was on parents of children ages 2 to 6 and we expanded that to 2 to 9, but they were like, we need programs for 0 to 2s. And so we are working with UNICEF to integrate the care for the child development package that they have so that it has the same delivery mechanism as the Parenting for Lifelong Health program so that it can be delivered by the same people. So in that sense, it's piggybacking on now expanding the services to early childhood, and that's being more integrated within like the nutrition and health aspects of ECD as well as the caregiving. And also, like, if there was a built system and there wasn't somebody, like, if you're actually thinking from a selfish level of a specific intervention, that would be possible to fit within the system, that would be great, because we really don't want to be competing for resources, but really to magnify the ability to serve people. So, thanks. The challenge is that there's no one silver bullet. And that's what sometimes funders and policymakers want. They want, can you do this and this and this and this and this? Can you do sexual reproductive health and digital parenting and child marriage and violence against children? And can you do it in 5 sessions, please? We're just like, it's not really possible. So it's sometimes you have to also temper the expectations. And looking forward, I would hope that we could do more sophisticated trials where we can then look at those who do well and then those who don't, and then look at what kind of interventions are necessary for those who don't respond to the primary or the universal service. Thank you.
Other questions? Okay, actually they are. I didn't see. There are two.
The other day on LinkedIn, I listened to a psychologist talk about an app he developed where he would connect people who could simply help each other. So no long, costly programs, just connecting people who think they can help each other. What do you think about such a...
Well, it depends on what kind of help. It'd be the same as if you had just different people coming together in a group, and that can go good or that can go bad,
Yep.
you know. But about the app, we are trying to develop an app for the parenting program for parents and adolescents. And we have some seed funding to do that. So that would be to take the content of the program and take them through the process. But then we can also test the difference between whether you need to go through the process like on a sequential base or can you pick and choose. So there's lots of opportunities to apply that factorial design to the best way of delivering an app-based parenting intervention. And this is going to be focused in sub-Saharan Africa, but the potential will be that it will have a less of an effect but a much wider reach. And so you can deal with the less effect because you're actually reaching millions of families. And then maybe there could be a referral process to the more engaged person-to-person intervention. And so we hope to have a prototype ready by the end of next year that we'll be testing in Kenya, Nigeria, and in South Africa. So thanks.
I wanted to bring up the issue fade out that you also mentioned in your talk, and you also showed all this evidence that points to positive effects in the short-term range, and I think from my knowledge of the literature, there's actually a dearth of studies that show long-term effects, especially with regard to child developmental issues, not so much parenting perhaps, but child development. And those studies, the few studies that exist, actually bring up mixed results, right? So what we have been thinking in Zurich, and what I'd be interested whether there are any thoughts on that on your part, is really linking data from RCT with administrative data that can be followed longer term without having to get access to the same people, again, using personal identifiers such as social security numbers and so on, which could be an interesting, I think, way to expand our knowledge on long-term effects of such parenting.
Yeah, we have been quite insistent in many cases to maintain the integrity of our trials so that something like this could happen. I think it would depend on the quality of that administrative data. So in certain areas, maybe it will be harder to follow. But for those, for instance, who are in the Philippines in that trial, because they're part of a conditionality that also monitors the school engagement and other health outcomes for the children, we could look at that on a longer term. I guess my concern would be now that we're seeing already the fade out effects, what can we do to sustain these effects, and how can we test that as a component within the intervention? But definitely, I think that would be a great way of harnessing existing data. And that's somewhere how we're trying to move towards, is how can you use either routine data that's being collected by an agency or by governments to look at that long-term effect of an intervention. So thank you.
Okay, well, let's keep the questions for the cocktail. We're out of time. Thank you so much, Jamie. Thank you.
Thank you, Nevena. Thank you.